It's always nice to be back in an educational institution. It makes everyone feel younger. I'm very, very envious of teachers, especially primary school teachers, because they are the ones who are dealing with very young lives. Little less envious of middle school, and then, of course, high school, graduation. As you grow older, life molds you, morals change, ethics, sustenance. There is a lot of dilemma that constantly goes in everyone's mind. And it's important to meet like this, get together, brainstorm, and reroute ourselves and understand the true purpose of life, to understand what exactly is the definition of success, and to look back and reflect whether we're just looking at morals, we're looking at money, or a balance of both, or what we leave behind to society. I think that's the fundamental thing of all life sciences, sort of to say, what is the purpose of life finally? Today, I bring greetings from Vaidehi Cancer Center, commemoration of World Cancer Day, February 4th. The theme of the last few years has been to close the care gap. And in the next few slides, we'll probably discuss a few things about cancer and we'll see how things go about. How many of you are more than 18 years old here? Everyone's more than 18? Wonderful. All of you have sort of a voter's ID and you're ready to elect your own representatives, right? Excellent. How many of you have a savings bank account dedicated for healthcare needs of your future? Nice. I'm very impressed. There's one person who has that. See, thinking needs to start, planning needs to start early. Like Madam was saying, there are a lot of inequalities that you will face in life. And when we are young, we don't think too much about what the expenditure later on might be. Today, it's all about going and watching and subscribing to Netflix, watching that gold class movie, getting some extra nachos and popcorn perhaps, going on a boat ride, traveling some travel to Lakshadweep versus Maldives, and a lot of politics. Some of you might want to go to Ayodhya temple and see, okay, well, let's see what's the big deal about. But are we really planning our healthcare needs? It's something that all of you young minds should start thinking. You'll be surprised. Go home today as an exercise and ask your own family members how many of them have thought about their possible healthcare needs and investment and saving for that. When I say cancer, what are just all of you close your eyes for a minute. Just think of about 10 words that come to your mind when we say cancer. Once you're done, you can open your eyes and see if you got any of these words. You know, as soon as someone says cancer, everyone's thinking about chemotherapy. There's a lot about uncertainty. There's about pain. Death is again a very big thing. Like when you say cancer, many people think it's a taboo word. Hospital, oncologist, someone might think of insurance. Someone might think the commonest cancer in women, okay, breast cancer, disease, side effects. What are the ways to avoid these things? Maybe you're thinking about acupuncture, you're thinking about yoga, how to control this disease. Happy times versus, you feel sad. You might think of God. You might think of prayer. You might think of asking for help. You might think of how to deal with hope. Cancer is a term that elicits varied emotions from different individuals, and from the same individual, a different set of emotions. We don't want to look at it in terms of just surgery, chemotherapy, radiation, multimodality treatment. That's not where we are today in 2024. It is a multimodality game, and the game starts with the mind, wherein you need to counsel people, you need to make people more aware, you need to sensitize people, you need to understand the varied set of emotions that come from being diagnosed with cancer. You'll be surprised, people are not worried more about themselves. They're generally worried about family members. Sir, will my children get cancer because I have cancer? That's the first question they're asking you. Because that's what we are trained to. We care for our family. Sir, is cancer contagious? If I touch, if we share the same plate, will we spread cancer? Again and again, we come across these things because the awareness is still lacking and there's a lot of stigma associated with cancer. Worldwide, the cancer burden is going to be about 27 million new cases by 2040. India's cancer burden is 29.8 million by 2025. This is our estimates. About 100 out of 100,000 people are going to have cancer. Numbers are increasing. 1 in 20 women are likely to develop breast cancer in their lifetime. So what exactly is cancer? Anyone has heard this term carcinos in the news? Chain of hospitals, they've newly started. There are carcino centers all over, they say. So apparently it was derived from the Greek word which means crab. Cancer looks like a crab with tentacles spreading everywhere. And Hippocrates was the first to use the word cancer to describe these tumors. Just to sort of instill words in your head for the free reader, those who want, it's all available on the internet. My talk here is not, it's just meant to, seed words. Yes, what are the various things that you would like to read about if you want to read? What is sustaining proliferative signaling, evading growth suppressors, non-mutational epigenetic programming, avoiding immune destruction, enabling replicative immortality, tumor-promoting inflammation, polymorphic microbiomes, invasion and metastasis activation, accessory angiogenesis, vasculature, senescence, or how cancer deals with genomic instability, resisting cell death, deregulating cellular metabolism, unlocking phenotypic plasticity. So for those interested to further pursue careers in immunotherapy, immuno-oncology, nanotechnology, biotechnology, it's all there. It's all leading to cancer some way or the other if you're really interested in that kind of research. These are what we call the hallmarks of cancer. It started out as just 6 hallmarks, and in 2024 we have all these hallmarks. Each cancer is like any of us. None of us are similar, right? Except probably like identical twins. Very, very heterozygous group of people wherein you have different things that cause cancer, different ways in which cancer is treated, and it's important to have this in the back of our mind when we plan our treatments for cancer. So can any of you, just think, what are the myths associated with cancer? Why have this awareness at all? What are the common things that we think? Just think about it. We'll go through each one of them. There's no cancer in my family, so I can't get cancer. Many people feel we have a very strong set of genes. Grandparents were healthy, great-grandparents were healthy. We're all going to be fine. I don't want to scare any one of you. That's not the intention. But we often feel that there is this sense of invincibility. Like no disease can affect me because I'm very healthy. I don't need to invest in health. I don't need to get preventive health checkups because there's no cancer, there's no disease in our family. Some people might think cancer treatments are very toxic. You'd have heard, right? There's loss of hair, there's ulcers, there's weight loss, people going through chemotherapy, people going through radiation, and these are actually going to make cancer worse. Cancer is a fake disease. You'll be surprised. There are lots of people who think there's a whole pharmaceutical industry making millions of dollars and millions of rupees in inventing drugs, nanoparticles, saying that this is going to cure. Yes, it's important to remember that everything should be weighed with evidence. In today's generation, don't take anything blindly. Just because Bharat came, he said that pharma industry is very good. Don't believe me. Don't believe your teachers. Believe yourselves. Investigate. I know they might all feel a little offended if I say don't believe teachers, but because if we just believe what people tell us, we will not think on our own. It's important to question everything in our own heads, try and evaluate it. Vaccines. I'm sure all of you have heard about autism and polio vaccination. You've read. Many people in the US still don't, take vaccination, or even for that matter, COVID pandemic. Did you have a friend who said, I don't believe in vaccination? You've had some group discussion saying, no, vaccination is causing strokes. We don't know. The truth is, we don't know. Maybe they did, maybe they didn't. Risk-benefit ratio, we're always weighing. The benefits at that point of time seemed better to take vaccination than not. Today, if I were to ask you to take vaccination, the risk benefit is probably equal. All of us have had exposure to COVID. You'll think 10 times before saying, okay, go ahead and give me an injection. That's how it is. So always think knocks and traumas cause cancer. I have an accident, I'm going to get cancer. That's not true at all. You won't lose someone you love to cancer. See, this is what we call hope. We always have wishful thinking. We don't want to hope bad for anybody, right? None of you are going to, at the end of the day today, say, Bharat sir, I hope your cancer treatment gets well done. You're rather going to say, Bharat, I hope you don't get cancer. So we always hope for the best, but remember that it's important to be a little realistic and not always idealistic. There is no treatment for cancer. That's not true. A lot of people still believe, no, stage 3, stage 4 cancer it's stage 4, sab jagah, it's spread everywhere. There is definitely no cure for, that's not at all true. Things are changing. Even stage 4 cancer can be completely cured. All cancers are treated the same way. Surgery, chemo, radiation. Surgery, chemo. That's not true. There's immunotherapy now. There is gene therapy. You might have read in the newspapers, India has come out with a new vaccine called the CAR T-cell therapy, right? It's all about harnessing one's own immunity, one's own T blood cells, in order to go and target cancers. And cancer is a death sentence. This is what we don't want people. We're talking a lot about these rather morbid sounding issues because these are the common things that come up when, people talk of cancer in a hush-hush voice. A large part of it is because we are not trained, we feel deficient in communicating to our loved ones about choices. You'll find a lot of educated people, not the uneducated, educated ones saying, I don't want my parents to know that one person has cancer. They are going to get shocked when they hear this news. Those things have to change because the way treatment goes now is all about choices. Not letting someone know what they have literally amounts to not allowing them to choose what they want to do with their life. Maybe someone who is 90 wants to live till 100. Why are you assuming that this is a 90-year-old who can't tolerate chemo and radiation? Let's not take this 90-year-old for surgery. Maybe their lifetime ambition is to hit a century in age, right? Maybe there is a 60-year-old who says, I've done enough with my life, I don't want any treatment. Is it right on your part to push them to all sorts of treatment? Maybe there is a treatment that's just tablets. Maybe there is a treatment that is just one shot of radiation. So there are so many ways in which we can now treat cancer that it is no longer one size fits all, right? That's sort of a part take-home message that there are many, many treatments available. It's freedom of speech, freedom of choice. We must understand how to accept this diagnosis, how to feel sad about the diagnosis, how to communicate the diagnosis, as well as help people with the diagnosis make their own choices, and for us to be supportive of their choice and not be judgmental of their choice. It's extremely similar to marriage, right? Everybody should have a choice whether they want love marriage, they want arranged marriage, they want to have a live-in relationship, they don't want to have a live-in relationship, they want to have an open marriage. We are in 2024. How scientific evolution is happening, how technological, industrial evolution is happening, so is the emotional evolution, so is the cultural evolution. It's one's choice. You're not going to allow someone who's 8 years old to make a choice that is probably harmful to society. My choice is to kill my teacher. I'm going to take a gun and shoot the teacher down. Okay, stay down, buddy. That's not going to happen. That's not freedom of choice, right? You make calculated decisions. Similar is cancer treatment. So whenever you think of cancer as a diagnosis, think of what you'd do if you were to get married to somebody. Will you just listen to your parents say, "Nahin, you have to marry this girl"? Maybe you don't want to marry the girl, you want to marry a boy. Who knows? So don't be forced because the doctor is saying. Now, this is something that we doctors and surgeons also tell ourselves. Why? Because as clinicians, we want to cure everybody. My aim, my Hippocrates oath is to say, I want to cure you of your problem. And I will put in all efforts to clear you of the disease. But is the clearance of the disease giving you quality of life? That is something you must ask yourself. I shouldn't be making those judgments, because unfortunately we've had situations where we've been humbled, where you do a fantastic operation, give a permanent stoma to someone, and the lady cannot even afford a stoma bag. And you have handicapped 15 to 20 years of her life. You have cured her, but she has no money to take care of herself. Nobody around her wants to see her feces coming out from her abdomen. That's what is a stoma. We make a bag, we remove the intestine wherein there is a disease and cancer. We do a bypass called an ileostomy or a colostomy, and we put a bag around it, and nobody wants to give her company. She doesn't have money for stoma bags. Her hygiene has now nowhere of concern, but she's alive. Is that what we want at the end of treatment? So we doctors are also learning. We are constantly learning and changing our practices. So evolution of cancer, despite our advances, it's amazing when we learn cancers are also evolving, adapting. So that's why we need to kind of, research and development is very essential. At one point of time, I didn't want to do medicine actually. I wanted to just BSc, MSc, PhD, get into pure science research and develop some new molecule that will revolutionize treatments, because that's as essential as taking that molecule to thousands of people and making them cure from disease. So this, I think it's very theoretical. I will not go too deep into it, but it's one point I'd like to know is, for any sort of cancer, we have these phases. We have a preclinical phase, we have a clinical phase. When we say clinical phase, that is the onset of symptoms and signs. That's when most people come to us. They have a lump in the breast, they have bleeding between menstrual cycles, they have a new mole that has developed which is itchy and which is largely increasing. There is an ulcer which is not healing. So those are the clinical phases. But before it reaches that stage, it's been in the body for a long time. And that is where our preventive, I think from a very Indian Cancer Society or research or preventive, like from a national program point of view, we are looking to target primary prevention, wherein we say, do not smoke, because we know smoking causes cancer. Do not consume tobacco, because we know tobacco can lead to cancer. Does it mean everybody who is having tobacco gets cancer? Answer is no. But the risk reduces. Everybody who is exposed to sunlight does not get skin cancer. But people who are susceptible to skin cancer because of excess sunlight exposure may develop skin cancer. So exposure is where we look at primary prevention. Between onset, we have early detection that comes into picture through screening programs. Absolutely healthy individuals like all of us, no symptoms. But when we undergo screening, there may be a chance that somebody has cancer. So primary prevention is all about physical activity. Obesity is known to be a very significant risk factor for cardiovascular disease, established. It's also a risk factor for certain cancers, especially breast and endometrial cancers in women. Tobacco, of course. Sunscreen use. You'd have heard, right? Australians, you see Australian cricketers coming out, they use a lot of sunscreen. Why? Because in Australia, ozone layer is depleted. They're exposed to more ultraviolet radiation. They're inherently at a higher risk of getting cancer. Secondary prevention will come. I have a lot of slides which talk about specifically screening and secondary prevention. And of course, tertiary prevention, where you have adjuvant interventions, prevention of second malignancies, and so forth. So like I said, it's not one size that fits all for us. We have to individualize treatment. There is evidence. You look up guidelines, trials, various forms of literature. You look at the feasibility of using those guidelines in your practice. You have a daily wage laborer for 150 rupees and you're proposing a treatment that costs him maybe 1 lakh every 15 days. Do you really think it's feasible? He's going to say no. You've got to tailor your treatment to what they can afford. It's an interesting option if you can arrange for a loan, arrange for insurance, arrange for a government scheme to help him out. If not, you'll have to look at feasibility. And this is why I started off initially saying ethics and morals, evidence, real life scenarios. In an idealistic world, we would want to give the best quality treatment to everybody. But is it really feasible? Sometimes it's not. But what is feasible is prevention and awareness and education. There are a lot of preventive strategies which are cheap, which universally can be applied, rather than treatment strategies which are not so affordable across all tables. Compliance, this also we spoke about. Many people might not want your therapy. They might say, I'm sorry, doctor, I want to go to Nati Aushti. I want to go to Ayurveda. I have a homeopath who has told me. Convince them, explain to them, but don't be pushy. They have their own belief systems. It's your job as a caregiver or a person in society is to actually be unbiased about other people's opinions, but give evidence based information to them so that they can make their own decisions. So, in terms of treating particular cancers, another word I would like you to get sensitized to is MDT, multidisciplinary tumor boards. This is because we have moved a long way. I'm a surgeon, so I often put this slide across to say there was a time when Halsted said, a lady with breast cancer, you have to remove the entire breast, remove the axillary nodes, remove few ribs, remove some muscles of the chest wall. She'd land up with a huge arm because there's no lymphatic drainage. And that was it at that point of time. Then they came about functional outcomes. Does the patient really want to do that or not? So you take into consideration what they want. Patient-informed and directed approaches. And that's why it's important to sensitize people we know about cancer and its therapeutic options. There's conventional neoadjuvant chemoradiation to targeted therapy. That's another evolution that's happened. Like I said before, it was only chemoradiation. Now we have something called targeted therapy. We do genomic analysis. There are certain driver mutations that are the root cause of cancer. If the person is lucky enough to have the driver mutation, you use a specific molecule and the person is probably cured of cancer to the extent that you can actually preserve the organ. Cancer can be completely wiped out, like how you do for diabetes. Is there a predominant surgery that deals with diabetes? You look only of, weight reduction strategies, bariatric surgery. So hypertension, you take medicines to keep the BP under control. Similarly, cancer is moving from sort of a definitive disease to more of a controllable disease nowadays. So this is just to sort of break the monotony. Everyone's interested in science and technology. So there were times when we started learning way back in 2012. My first operation which I had done for a cancer patient was an incision right from the chest till the groin, like one big incision, opened the entire abdomen, looked at all the organs. But now it's all keyhole and single port. We do a lot of minimally invasive surgery. And a lot of you will be fancy. This is the robotic Da Vinci. There's an XI system. Intuitive is the company that's come out with the first robot. There are lots of robots in the market, and this is the XI. So the surgeon can aram se sit. I can actually sit here if I have a console, log into my 5G network, and probably operate someone on Whitefield. That way I would have been on time maybe. So these are things that are coming up in technology. While we are happy with the robots outside, a lot of researchers are happy with the robots that go inside. So you have nanotechnology and nanorobots. You inject robots into the bloodstream. You can inject minute robots into the tumor. And each of that small miniature thing will carry a particular drug, will carry a particular target. It goes, affects that particular cell alone, and there's an attempt to cure that cancer. And of course, anyone who can identify what's there, that's a DNA analysis, a genomic, it's a whole genome analysis. And again, that's very essential because now we are subjecting everyone to whole genomic analysis so that we can find these targeted mutations. So warning signs like we discussed, bowel habits. I used to pass one big dump every in the morning. Now I pass 4 or 5 times I need to take, off to go to the bathroom. I wake up more than 5 times in the night to urinate. There's blood in the urine. There's blood or black stools. There's an ulcer in my oral cavity, in my cheek. It's not healed for the last 3 months. I noticed a loose tooth. There's a small ulcer there. I've been applying some Smile ointment. It's not healed at all. Any lumps in the breast, lump in the abdomen. indigestion, unable to eat, changes in the color of a mole. Black moles become suddenly bigger. It started itching, it bleeds now. Lots of cough, hoarseness of voice, change in your voice. Unexplained weight loss. That's what we say, significant weight loss, pernicious anemia. It's very interesting. Till probably 2-3 weeks ago, in a Viva Voce examination, when someone asked us what is significant weight loss, we'd always insist that we answer unintentional weight loss. We used to say unintentional weight loss is significant weight loss, 10% of their body weight in 6 months. Recently, a paper was published wherein they said people who have intentional weight loss are at an equal risk of having cancer. Especially people who have tried to lose weight, have been unsuccessful, suddenly they change a particular diet and they become successful. These are again warning signs. I'm interested in that because obviously you can see I'm not someone who's lost too much weight. I've not been successful with it. But even intentional weight loss can be a warning sign of cancer. Why is it important for anyone to notice? You'll be surprised. You'll hear these things in random conversations, random WhatsApp texts. Someone says, no, yaar, today I'm not coming for the movie because, I have a very bad sore throat. I've been having cough for the last 3 months. Very bad cramps this time. I'm getting cycles twice a month nowadays. You never know what these could be. These could be a warning sign. Important thing is not to panic, to visit a healthcare provider and have your doubts clarified. And they will slowly, based upon a detailed history, make an assessment if further investigations in the form of a blood test or in the form of some ultrasound or a CT scan. Depending on that, you take one step at a time. So we are going to now change our focus to not warning signs picking up when things are obvious, but rather when things are not obvious. Like, what is screening? It is the application of a test to an asymptomatic population, like any one of us, we are all asymptomatic, and to determine who is likely to have the disease and who may not have the disease. It is a systematic routine application of a suitable early detection test at specified intervals. We'll come to this. It sounds like it's repetitive, but you'll be surprised. I think you would have heard these stories, like when Puneet Rajkumar died. He was perfectly fine. Just 3 months ago, he had gotten all his blood tests done. Everything was all right. He's had his ECG done, echo done. Then what happened? Because it's not a one-time screen. You understand? It's a repetitive assessment. It's a continuous assessment. You don't say one exam at the end of the year. You have someone evaluating you throughout your course. So even that one day practicals goes wrong, you have an internal examiner saying, no, this is a good candidate here. Today is this bad day. Please pass this candidate. Something like that. So what's an ideal screening test? I found this picture off the internet. How many of you think this is like an ideal screening test? Can anyone identify what's happening here actually? Temperature check, very good. I'm sure your college also did this, correct? During COVID time? How many of you think that's a very, very good way to detect if someone had COVID or not? In hindsight, you would have had lots of classmates who cleared that, came, sat with you, gave you COVID, got COVID, took 2 weeks off, right? So screening tests are also evolving like that. It's not something that we have found the perfect answer to. So holding an infrared camera, the camera can go wrong, his forehead might not be warm, the distance is a problem, the valuation, the numbers, there are 101 things that can go. A person might not even have fever and have COVID. So we learned that much later, not at that point of time. So when the college did it, they did a good job. And they had to do it because sometimes, like you'll probably hear, national programs, politicians have to say that they are doing something. It's very difficult for man to sit back and say, okay, we don't know, we're not doing anything. You've got to constantly do something so that you can evaluate whether it's actually correct or wrong. So characteristics, the disease should be an important public health problem. So in Japan, there is a screening for stomach cancer. Do we have a screening program for stomach cancer in India? No. In Japan, there is a national screening program for stomach cancer. Why? Because it's very prevalent. Why is it prevalent? They all eat processed smoked fish, aniline dyes. That's high risk. Their genes are bad. There's a lot of genetic predisposition there. So it's important to screen. It's a public health issue. The natural history should provide a window of opportunity for detection. Let's say you have a tumor that's going to grow in 10 days, 15 days, 30 days, very aggressive type biology tumors. You can't screen them. The person will develop a very severe disease between screening intervals. If I say I'm going to do a screening test every week, would you guys like to go to the hospital every week? There's no point. If I say once a year, okay, maybe there is some hope. Once in 3 years, 5 years, there's more hope. And that is why colorectal cancer programs are far more successful, because you screen them 3 and 5 years. Cervical cancer screening is successful because it's long term, 5 years, 10 years. You do one negative test, you don't have to come back sometimes. Whereas screening for oral cavity, buccal cancers are rapidly progressive. People are continuously chewing tobacco. There's a small ulcer. It's become rapidly progressive in, 30. The screening might just be an oral cavity examination, but how often do you do it? So the natural history of certain cancers give us an opportunity to pick up disease early. There should be an effective treatment. Prostate cancer. You'll probably die with the prostate cancer rather than because of the prostate cancer. Is there a point in really picking up prostate cancer in stage 1, stage 2? There's no effective treatment. You're going to give him poorer quality of life by, reducing his testosterone levels. So it's not something that's picked up too much here in India. The treatment should be more effective when you start it early. Breast cancer. Smaller the lump not palpable, picked up by a mammogram, removed, potentially cured, no need of any further treatment. So it's important for the treatment to be effective, and it should be available, that's accurate, it should be acceptable to the population. See, that's again very, very important. There are certain populations who will subject themselves to certain tests. So look at cervical cancer in India. In India, human papilloma virus, which is known to cause cervical cancer, has a vaccination, but our acceptability rates for vaccination for HPV is 20%. How many of you have had vaccination for HPV here? Raise your hands. Very less. How many of you think that only women should have HPV vaccination and not men because it's cervical cancer related? Everybody agrees that both men and women are eligible for HPV vaccination? That's how it should be. Because oropharyngeal cancers are also known to be caused by human papilloma virus. It's very easy to sit here and say, yes, we've got to make a change, but the change has to start from us. We need to understand if 9 years to 45 years, anybody, male, female, they're eligible for HPV vaccination. And it is important because India is a huge country with a growing population. It would be foolish to think that there is no sexual activity in India. Promiscuity is very, very high in India. These are again idealistic versus realism. If you have people with very, very high ideals sitting and making rules, you'll say unmarried women do not need to have HPV vaccination, which is a very, very ineffective statement because it doesn't reflect what is happening in reality. So there needs to be a balance of all this for policymakers as well. And there should be an appropriate screening strategy. So they should have high rates of participation from eligible population. It should take into specific resources available. If I say screening for pap smear and cervical cancer, it's cheap. Mammography is cheap. But colonoscopy, endoscopy requires a day's preparation. If everybody agreed to have a colonoscopy today, there'd be no hospital which could accommodate all of you on the same day. There'd be wastage of resources. They should be sensitive to patient, and they should allow a prompt follow-up of positive tests and prompt treatment, and the programs, of course, should be cost-effective. They should also be monitored and constantly evaluated to look for changes. Anyone, any idea what is happening here? Someone's looking at a microscope, slide in his hand. What might he be looking at? That's the PAPS test. That's George Papanicolaou actually looking at, cervical cancer smears to see for abnormal cells. It was just taking a swabbing the cervix, swiping it on the slide, putting a few drops of Papanicolaou stain and looking at it in the microscope. That was sort of a revolution in cancer screening. And why talk about screening? We already discussed this. Early detection and treatment. It reduces morbidity, improves cure rates, and very importantly, it reduces need for multimodality treatment. A breast cancer which is diagnosed by screening needs only surgery. Something that is palpable automatically needs chemo, needs radiation, needs hormonal, probably even immunotherapy now. So it's important to screen and pick up these lesions early. Which is the commonest cancer in India? Sure, because it's on the top of the slide. How many of you say lung cancer? Okay. How many of you say breast cancer? How many of you say breast cancer in women and lung cancer in men? Possible? How many of you think actually it's oral cavity cancer, tobacco related? That's the thing. The commonest cancer in India is actually oral cavity cancer, tobacco related cancers, because tobacco chewing is very, very rampant. Among women, of course, breast cancer has now overtaken cervical cancer. Probably because cervical cancer screening programs to an extent are doing something. There's probably slightly better awareness. There's more access to health needs at early stages. And obesity, lifestyle changes are contributing to an increased risk of breast cancer itself. So both ways, breast cancer has taken over cervical cancer in women. Colorectal, is it popular in India? It's about like the ninth leading, it's nowhere up in the list. But what happens if you move to the West? It's like the second leading cause of cancer death after lung cancer in the United States. With westernization, that is something that we are going to see more and more. A sedentary lifestyle, high processed foods, processed red meat, constipation, lack of fiber, lack of exercise, all these things indirectly contribute to colorectal carcinogenesis. And it's likely that India by 2040 will probably be the fourth largest, leading cause of death because of colorectal cancers. And there is prostate cancer. So perceptions of, you might be wondering, okay, here's a doctor, he's saying everybody gets screened. But what is the medical community actually doing? It's interesting. I wanted you to realize that, doctors around you are also not foolproof. We've done a bit, but our society, we're just like the common folk. You look at perceived effectiveness of various screening strategies. This was a survey done on family physicians and internists. They're all doctors who are taking the survey. And you'll realize that there are significant number of people who said that, prostate cancer screening is not effective. Some have said minimally effective for pap smear screening. I'm someone who'd probably say it's all very effective. But it's not 100%. You realize? So evidence is, if you go to a doctor who's not really convinced about screening, you'll probably find one. That's why patients do a lot of doctor shopping, right? You don't like to go to that doctor who tells you the worst things to do. You'll be like, no, dusra jayenge, ye sirf one paracetamol, ella sari hotogote. Because this again, you're hoping for the best. It's not a wrong thing. Please take second opinions. It's always, two minds are always better than one. But make an educated, collective, informed decision. This is an alarm signal from National Family Health Survey. You look at it, screening in India is practically nothing. We all talk during this February 4th, that 1 week, a lot of screening. Then tomorrow I'll go back to my practice. I have an OPD, I have OT, I have ward rounds, I have teaching schedules. How much am I contributing to promoting and making people undergo screening? Less than 5 minutes a day, perhaps. And that is why these awareness campaigns are very important. That is why Indian Cancer Society has taken it upon themselves. This app that is there is all going to be far more, because you reach out, each one teach one. Like if all of you spoke about cancer screening for 2 minutes a day, maybe it will translate to some improvements down the line. The more we talk about it, the more we'll get convinced about it. Staff room lunches. You're all far more younger. Your teachers are far more receptive. During their lunch breaks, they say, okay, no, all of us above 40 years, 45 years, we should all go get a mammogram done. Every year on my birthday, I'll go get a mammogram done. Once in 3 years on my birthday, I'll go get a colonoscopy done. Speak to your parents. Speak to your aunts, uncles, family members. Understand their knowledge, attitude, and practice towards screening. You'll be surprised. You do a good Google research and you will be convinced that yes, tomorrow sab log aayenge, we are going to this hospital, Vaidehi, Dr. Bharat, we are all coming tomorrow. None of you will turn up. Nobody. First of all, they'll say, how much is it? 1,200 rupees mammogram? No. I don't. What is the point? I have no problem. Correct? Denial. That's why we did that whole cycle of myths. When you actually apply it, you'll realize that each one of your family members is going to use all those myths. in our house, there is no cancer. I don't need screening. Nothing has happened. I'm very healthy. I don't need screening. Cancer is not going to affect you. I have protected you like Harry Potter, Lily Potter. My protection is on this child. Love. You will not fall sick. You'll be surprised. This will happen in your own houses. Try motivating one member of your extended family to undergo screening in the next 1 month's time. Keep it as a target. Choose anybody and target them like a homework. Even one person, if you can do, you'll make a difference probably to them. Are medical professionals at a higher risk for cancer? This is something. We are doctors, we're in and out of radiation units. Actually, yes, there is some evidence to say that internal medicine people have very significant higher risk of cancer. Radiologists, surprisingly, just have much lesser risk of cancer. And that's interesting to note. These are just statistics. But yes, medical professionals are at a slightly higher risk for cancer. Why? Nobody knows the answer actually. But there is a slight preponderance. So what are the knowledge, attitude and practices regarding vaccination? I told you HPV. You'll be 76% of doctors will know about human papillomavirus. 68% know that there is a vaccine available for HPV. But amongst doctors, only 20% will be vaccinated. I'm sure all of you are curious, is Dr. Bharat Shankar vaccinated or not? Correct? I'm not going to give you the answer. I'm going to leave you wanting. Correct? But this is the reality. This is the reality to say that, medical professionals are also just like the general population. There is a lot of, gap between what we read and what we can actually finally do at the end of the day. So why do people hesitate getting screened? Fear of radiation exposure. Mammogram is an X-ray, annual mammogram, once in 6 months mammogram. Is that radiation harmful for me? Fear of diagnosis. Okay, if I'm diagnosed with cancer, then what? That family engagement is going to get stopped. Someone's wedding is going to get stopped. Someone's child has an exam to attend to. My own aunt waited. She actually had a polyp in the colon. She was severely anemic. She waited till my cousin's marriage to get a colonoscopy done, despite telling her, no, it's really essential. Why? Because the wedding is far more important. See, it's a social thing. Don't judge anyone. But there is always a fear of diagnosis. It's important to understand that, yes, there can be a fear of diagnosis, but there's also a cure available. The earlier we detect it, the better the cure rates. It's not that doctor hatra ಹೋಗ್ಬಿಟ್ರೆ ಪ್ರಾಬ್ಲಮ್ಸ್ ಹೇಳ್ಬಿಡ್ತಾರೆ. ಪ್ರಾಬ್ಲಮ್ಸ್ ಬರಕ್ಕೆ ಮುಂಚೆ ಡಾಕ್ಟರ್ ಹೇಳ್ತಾ ಇದ್ದಾರೆ ಅಷ್ಟೇ. So it's important to go to the doctor early. But you'll find that if you go to the hospital, there are continuous tests, diagnosed and finally, coming out on a stretcher types. Lack of conviction in screening. Many people feel, no, simply this doctor is asking, everything is normal. 5 years in a row, 45 years, 45 to 50, my breast mammogram has been absolutely normal. Shall I stop now? Answer at this point of time with evidence is no. 45 to 75. That is the recommended screen. So that's about 30 mammograms in a lady's lifespan. Correct, ma'am? It's surprising. It's a large number. But that is the recommendation as per evidence right now. Annual mammogram from 45 years of age to 75 years of age. Western countries are actually moving to 80 and 85 years of age. Why? Because they value their old age. In India, we feel 75 is kafi. If someone has lived 75 years, she can get cancer next month and die, no problem. I'm telling you, these are all funny attitudes, but you'll see these things. 80-year-old aitupa. Death in a family. First thing, what will you ask? What is her age? If they say age is more than 70, Papa, vaisagittu. Correct? Why now? You live till 100, live till 120. The Japanese are there. There are 120 years. Nobody is aiming. You're not thinking. You should reach out, reach high, reach beyond. That was a slogan of National Public School. That's where I studied. And that's where you say, why do you limit yourself to 90 when you can live till 120? It's important. Fear of complications. While doing the screening test, what if they make a hole in the colon? It's a very real fear. It happens in less than 1% of the population. But yes, it can happen. But there's a treatment for that. Mammogram, unlikely to have complications. Pap smear, unlikely to have complications. But what happens in pap smear? There's inhibition. You're not a sexually active person. Why would you want to go have yourself examined by somebody putting a swab there? It's not something that anyone would like to do. So these are all real things that we as medical professionals work on day in and day out to try and let that inhibition out, to say, no, you've come to the doctor, please don't feel scared, don't feel threatened. Diagnosis is good. Early detection helps save you. Feel free. That's how we go about screening. Benefits definitely outweigh the risks, and that's why screening is important. Screen detected breast cancer cure rates are about 90%, whereas in non screen detected breast cancer, it actually drops to about 40%. So, if the worst biology, breast cancer, is actually picked up, triple negative, very bad, rapidly progressive breast cancer, 90% screen detected, you will get cured fully. When I say cure, we are thinking of 5-year, 10-year, 15-year, 20-year survival. So at 70 years of age, if I'm able to give 20 more years to a lady without any cancer, I think that's a very good thing. You feel happy about that. So annual mammogram after 45 years of age, pap smear once in 3 years or 5 years. You can use it with HPV DNA co-testing. There are a lot of guidelines. This is just one of those guidelines we have taken. A colonoscopy after 45 years of age, low density CT scan. This is something that I realized it was a learning point for me also. Generally, when someone smokes a lot, close family person, you keep telling them smoking bidi, smoking bidi, smoking bidi. They don't give up smoking. They're addicted. They need proper psychiatric counseling and de-addiction to help them get away from it. We are biased because we think that they are also not going to undergo tests which are the consequence of smoking. You stop telling them to get a CT scan for looking for lung cancer. You don't tell them to get a lipid profile to look at their lipids, a CT to look at their coronary heart disease, or an echo treadmill test compared to the general population. There's actually a study that says, because they're worried about their life, unfortunately, they're addicted to smoking. Yes, prevention is the best way. We know that it's bad. But if someone's addicted, assess, ask, help, reach out, make sure they get it on a de-addiction program. But if that's not successful, you also have to learn to accept them. When you accept that they're not going to give up smoking, you can at least prevent the consequences of smoking. And if you do a low density CT and you pick up a lung cancer, they'll be more motivated to give up smoking than without you doing these things. So encourage everybody. Don't just assume that just because he's a smoker, he's not going to get screening tests done. So this is probably my last but one slide. This is NCCN. So this is one of the favorite guidelines. I'd like all of you youngsters to also look at this. This is the National Comprehensive Network, and they provide for patient guidelines, resources for doctors, for technicians, for everybody. So it's just a random screenshot which I've added today actually. And they help you find clinical trials. There's a lot of resource material out there which is now easily available on the internet if you know where to look for. And nccn.org is a good website. Just create an account, log in today, maybe spend about 3 minutes. Best time is if you're, how many of you have the Western commode? How many of you have Indian commode at home? Western toilets? Nobody, yeah? You raise your hands, be proud. Everybody does it. There's nothing to be ashamed of. That is the best time to go and Google NCCN. Correct? You're there for 3 minutes at least. You just type www.nccn.org. Yeah, I take liberty in making these jokes because predominantly I'm a colorectal surgeon. I deal with poop and every day, day in and out. So that's the good time for all of you to, brainstorm and look at these guidelines and sensitize yourself and spread the awareness. Thank you. Let's all hope to close the care gap. Happy to take questions. I think all of you, I'm sure if you have anything, we can all discuss. If I don't know, I'll say I don't know. You can all Google it.
Now, I'll start with a question first.
Yes, sir.
Nowadays, endometrial thickening is said to be a cancer-related issue. All endometrial thickening in female are going to end up with cancer, or is it something different out of it?
No, sir. Not all endometrial thickening. So normally in a premenopausal lady, a 3 millimeter endometrium is considered normal at any phase of a menstrual cycle. Between 3 to 5 mm, we consider it as borderline. More than 5 mm in premenopausal ladies, it is considered significant. If they have recurrent postmenopausal bleeding, especially in postmenopausal women, bulky uterus, thickened endometrium more than a centimeter, we often offer a biopsy, a DNC. Sometimes it can just be simple hyperplasia. It can be hyperplasia with atypia, hyperplasia without atypia. Not all of it translates to endometrial cancer per se. In patients who have a family history of Lynch syndrome, wherein there is MSI, there we reduce this endometrial thickening as a criteria. We say that we have to be on a high alert. So patients who have microsatellite unstable cancers, it could be hereditary non-polyposis colon cancer, breast cancer, stomach cancer, anybody, first degree relative, second degree relative, if they have something, in such patients we are more eager to do a DNC on the first visit itself. We put them on simple medications. Intrauterine devices such as Mirena are also often used in order to reduce the bleeding. So not all endometrial thickness translates to endometrial cancer.
Thank you, sir. One more question. This was a light moment when we shared with my friends who are in Europe. They said that the people who are surviving eating food, normal food in Europe or Western countries, they are prone to get all this colorectal cancer very often. But Indians don't get it because they eat more of sambar. They have that proportion of hing and masalas, especially the chili powder. They don't use oregano powder or any other chili flakes directly. So the colorectal cancer for Indians comparatively is lesser than that of the other westernized population. Is that true?
Partially probable. There are some epidemiological studies which have said turmeric that is present in sambar, antioxidants, but predominantly what we can correlate is the amount of fiber that is there in diet. So even for those who consume processed meat, when I say processed red meat, I'm talking about pork and beef specifically, 1 cup with 4 cups of veggies is a good sort of balance in order to ensure good fiber. When the fiber reduces, the whole colonic transit slows down. When the colonic transit slows down, whatever carcinogens are there in that food act on the mucosa for a longer period of time. And because of that, they are subjected to some sort of carcinogenesis. Carcinogenesis also goes through that entire, process pathologically from normal-looking cells, initially becoming metaplastic, then dysplastic, then invasive cancer, and then metastasis. So there is a sequence of events that happens at the biological, pathological tissue level, which can be delayed by taking a high fiber diet, which can also be delayed by taking some NSAIDs. So there's this poly pill that has come into, like people ask us, is there one tablet I can take which will prevent all cancers? So there's a lot of research going on between combining metformin, which is an oral hypoglycemic agent, aspirin, which is a antiplatelet cardioprotective agent, and vitamin E tocopherol, which is an antioxidant, a combination of this. But if you ask evidence for it, very low quality evidence. There is no randomized control trial or meta-analysis or a review which has proven that this is significantly better in reducing the risk. So I wouldn't prescribe that to anybody. But if someone is already on them, maybe they are less likely to get cancers.
Good afternoon, sir.
Good afternoon.
First of all, I thoroughly enjoyed the talk.
Thank you.
As a life science student, I wanted to ask, are there any, if I wanted to go into oncology research in the future, what would be your suggestion into some certain, niches where I can, do extensive research on? There's obviously the search for a cure, a complete cure, but then apart from that, what would be a good research opportunity in oncology?
The most important thing from the life science perspective which comes to my mind is about assessing quality of life issues. Every treatment has to be weighed against what effects it has on patients and what quality of life you can improve upon. That's a big topic and debate for itself. There are volumes and chapters written across it. If you want to go in depth into molecular diagnostics, I'm not sure if that comes in the purview of your field of interest, But that's again something that you can look at. But there's scope in almost, even a chartered accountant can come and do cancer research. So it's limitless potential, because you're dealing with a lot of patients, you're dealing with a lot of emotions, you're dealing with factual assessment of data. Data collection itself can be a big boon, and anybody can do that. If you're really motivated. uh, I think Dr. Ravi Kannan, many of you might have heard sir's name. He's famous. He gave up his entire practice in South India, went and settled in the Northeast. He's won a Padma Award. A phenomenal surgeon who's done so much work by just saying, I don't want to remain in corporate hospitals in Bangalore. I want to go and do something in the rural area. And he's doing everything from scratch. So, any other specific thing that you are interested in, which I put you on the spot, threw the question back at you. Sorry about that. Please go ahead. Reach out to me. We can always connect,
Yes,
and
thank
then
you.
see if you're all interested in cancer research, doing a small project, doing quality of life, translational research, level 1, 2, 3 trials. There's a lot of scope. Yeah.
Thank you. Thank you very much.
Yeah. I think ma'am's asked a very, very pertinent question. Once a person is diagnosed with cancer, how do we go about discussing whether surgery is the first option, or chemo, or radiation? Like I said, ma'am, we put a group of minds to work. We do what is called an MDT. So we try and tailor the decision, and we always stage the disease first. So staging is very clinical and radiological. Clinical is when we do a clinical physical examination, we assess for the size of the tumor, that is the T stage. We see if it has spread to the nodes, that is the N, and we also see if it has spread beyond the confines of the body. Beyond the confines of the organ it started out. That's M. So we use the tumor, nodal, and metastasis TNM staging. The AJCC, that is the American Joint Committee, has created a manual, and each cancer is staged. We also do a biopsy, and the biopsy will tell us the grade of the tumor. That's where the pathologist comes into help. With this information, and looking at the patient's age, comorbidities, ability to tolerate treatments, we kind of formulate a plan. As a bird's eye view, if there is some tumor which has spread to all parts of the body, like a PET scan is done and it picks up more than one metastasis, these are patients who are more likely to respond to chemotherapy. We don't do the surgery per se first, we first give systemic treatment. If it's stage 1 disease where it's just confined to that particular organ, surgery is the first treatment that we go for. Based on the biopsy report of that surgery specimen, we then decide whether we need to add radiation to sort of sterilize the margins. Each cancer has different protocols, ma'am. That's where the NCCN also helps us. Some cancers, like rectal cancers, we give neoadjuvant radiation. Some cancers, neoadjuvant means before the operation, we give radiation, some chemo, we downsize, shrink the tumor, and then operate. Stomach cancers, we give chemotherapy before. Uterine cancers, we're more likely to operate them first and give adjuvant radiation later on. Breast cancer, again, depends on the specific type of breast cancer. Some are based purely on hormone positive disease, what we say. So estrogen receptor is positive, progesterone receptor is positive, 70 plus lady, good biology tumor, she's had a lump for 2 years. I would think of operating, and then based on certain molecular assays, decide whether chemo is actually going to make a benefit or not. On the other hand, very locally advanced T4 disease, it has spread to the chest wall, skin nodules everywhere. I would definitely give chemo first, then reassess, operate, and then also give radiation. So each modality of treatment that we add, sort of by 2 to 5%, improves the risk of survival, apart from surgery. Majority of the treatment still is surgical. You want to remove the tumor away. And it's a very important question, because most people feel there is cancer in me, why are you not removing it? Why are you giving radiation or chemo? Why are you not removing the tumor? By delaying it, are you delaying further progress? So that is why we say, evidence says that no, in this particular case, it's better to give you the radiation and chemo, reduce the size, make the operation more functionally acceptable. So because of that, instead of removing the whole breast for breast cancer, we can now just remove a part of that tumor. There's advances like in depth if we go, we can actually tattoo it by putting a small clip and then removing just 1 centimeter around the clip. That itself is sufficient if you have taken neoadjuvant treatment. So that's individually we do that, ma'am.
Sir, I wanted to ask about blood cancer. Like in the list of the cancers there, I didn't find blood cancer.
Fantastic. That's because I'm a surgical oncologist. I deal with a lot of solid organ malignancies where we operate. Blood cancer is purely the purview of chemotherapy. And in blood cancers, like ma'am said, you deal with a lot of children, especially lymphomas, leukemias, and it's curable with chemotherapy. It's curable with bone marrow transplant. It's curable with stem cell therapy. So those are the armamentarium for blood cancers. And I think I put up one last slide which had a chap with multiple myeloma. That is also a sort of, hematological malignancy. And that is dealt again with CAR T cell therapy. That's the one that is revolutionized, immunotherapy for those kind of cancers. It's much rarer in India, but it's
Is it
very...
it's not one of the common cancers.
It's not one of the common cancers. It's much rarer in India, and it's more common in the pediatric population. It's also common after treatment of certain cancers. So certain cancers that we saw here are treated with chemotherapy. There are certain chemotherapeutic agents which can actually cause blood cancer. So that is one of the side effects of certain chemotherapeutic agents. That's a very nice point that you brought out. Thanks.
To ask about the genetic variations cause cancer. So, are there treatments for prenuptial babies who have this genetic variations?
You're very, very bang on. So there's one particular cancer called the medullary carcinoma of thyroid. So in medullary carcinoma of thyroid, there's MEN syndrome. I don't know if it's part of your syllabus or not, I'm not sure. So MEN2B, that is multiple endocrine neoplasia, we do an exon mutational analysis. So based upon whether there is exon 834 or 904, 216, you classify them as high risk, low risk, intermediate risk. For high risk, we can always offer surgery within 1 year of age. Right now, in utero testing, risk-benefit ratio is not so good. But people with familial cancer syndromes, if they get married to another person with familial cancer syndrome, they have an offspring, there is a possibility where you can do a chorioamnion testing for genetic mutations. And then it's a choice whether they would like to continue the pregnancy to term or not. But no surgery is offered at that point of time. Another thing that is coming up is gene therapy. So CRISPR and Cas technology is now being routinely used, especially for sickle cell disease. And sickle cell anemia was one of the first that got cured. Maybe it will come to definitive cancers later on.
Thank you, sir.
Thank you.
Thank you so much, sir, for illuminating us with the ideas on cancer awareness. Please give him a big round of applause. So on behalf of the management, on behalf of the Department of Life Sciences, on behalf of everyone gathered here, I take this opportunity to thank Dr. Bharat Shankar for taking his time and addressing us on cancer awareness. I request Dr. Sonia Angeline to come forward. As a token of our love and gratitude, we'd like to present a memento to Bharat Shankar. So I request Dr. Sonia Angeline to do the honors.